opportunity. Here are my disclosures. So this was a study that we published in 2014 or so, but it was presented in 2012 at the 2013 at the SRS meeting in Lyon. And basically, what we saw is that when you have patients with PJK, those patients who actually required a revision for the PJK had higher post-op lumbar lordosis corrections and also larger sagittal balance corrections. So there was a period of time, I think, back in the early 2000s where there was a significant emphasis on sagittal alignment and lumbar lordosis, and I believe many people in this room who were many years in practice already at that point were probably remember a time period where they said to each other that you could never really get too much lumbar lordosis and you need more and more. But what we need to recognize is that that's not really how the natural course of things are. Just like you wouldn't expect a 75-year-old person to run a marathon in 2 hours, even if they were able to do it when they were in their 20s. The same thing goes for the spine. So we know that some of the historical data suggests that patients with SVA in their 40s versus 70s, on average about 3 centimeters larger, and their lumbar lordosis is also approximately 10 degrees less. And this has been verified also with full-length radiographs. So now with EOS imaging, we could image from the skull to the feet, and we're seeing very similar data. So lumbar lordosis between your 40s to your 70s, it decreases from 61 to 47, and your SVA increases roughly about 3 centimeters. Very encouraging to see that even with Scoli X-rays only, where you weren't able to visualize the lower extremities, we're seeing the same results. So here's an example of a 74-year-old patient who underwent a major revision operation for junctional kyphosis, pseudoarthrosis, multiple issues, and was revised up to T2, referred to me by a colleague. But then you could see here shortly after, there's an element of junctional issues that are occurring, and this patient actually fell in the middle of the night, developed a cord injury, and never really recovered. So let's look at some of the data here and think about how important age is when we consider alignment parameters. This is Steve Glassman's study that brought to attention the importance of ODI in relation to positive sagittal balance. But if we really look at this literature critically, what we see is that you don't really see an increase in ODI that's consistent until you get above the 5 centimeter mark. So actually, if we're correcting all of our patients to an SVA of 0, it's really not based on a good amount of literature for us, and actually maybe we should rethink our alignment parameters. This, on the other hand, is a T3 or T2 to pelvis type operation in a 40-year-old. So very different operation, but no junctional issues even 5 or 6 years out from the operation. So this has led some of the collaborative work through the ISSG and larger databases through multi-center collaboration to develop a concept of age-adjusted alignment thresholds. And basically, what we did was look at outcome parameters based on age and then sort of reverse engineered what the alignment should be for a given age group. What we saw is that when you age-adjusted versus went over that age-adjusted alignment, the overcorrection really provided no additional clinical benefit, meaning your MCID was not better, your improvement in all the outcome measures was not better, and actually all you ended up having was a higher incidence of PJK. So the principles of alignment are illustrated in this table here. I apologize that the font is a little bit small, but basically the pelvic incidence to lumbar lordosis mismatch when you're actually above the age of 70, 75 should really be about 17, something that maybe back in 2000 many people were considering to be flat backs. Also, in parallel to this, your SVA when you're above 70 should be around 8, as opposed to when you're in your 30s or 40s, it's about negative 5 millimeters or just under 0. So I think these are important principles for us to consider when we're thinking about consequences of junctional alignment issues. But I do want to say that it's not all about just the number of alignment as far as the parameters, but it's also as we're understanding alignment more and more, and I do believe that 10 years from now, I'll be up here giving a different type of talk with an additional theory and concept, but we also have to pay attention to proportionality as well as spinal contour. And of course, everything that comes with age is also the soft tissue envelope, frailty, as well as bone quality. So what do I mean by proportionality? Proportionality means that this is the Rousseli classification, but basically it's the apex of your lumbar lordosis in the preoperative state. So some of us may not see this because the patients many of them are under revision situations and their alignment is already very artificial in that it's been dialed in by prior operation. But this is important for us to distinguish because with your postoperative correction, you want to try to replicate this. If you change a person's apex higher than what they're normally supposed to have, then we've seen that there's a higher incidence of junctional issues. Also, the basic principles of where your lumbar lordosis should sit in relation to your pelvic incidence. Most of your lumbar lordosis is actually from L4 to S1. Approximately 60% of your total lordosis should be from this segment, and that has to be considered when you're doing this operation. It's not just the L1 to S1 total value, but it's also proportionality, and as we're understanding the nuances of alignment, it's becoming increasingly more complex for us to consider. So the proportionality is one thing here. Someone with a very low pelvic incidence is going to have a proportionally lower lumbar lordosis and a lower thoracic kyphosis. Meanwhile, somebody with a larger lumbar lordosis is going to have a larger pelvic incidence and a higher thoracic kyphosis to compensate for that. And this has also been reproduced through multiple other studies, even in the Japanese literature and Japanese population. What we could see here is that when you have a lumbar lordosis apex that moves higher and higher, and the proportionality of your lordosis moves up, your incidence of junctional kyphosis goes up significantly. So I think something that we have to definitely consider when we're fixing these patients. This is also an extension of the age-adjusted alignment parameters, basically demonstrating that as you move your apex up and higher up into closer to the thoracolumbar junction, your incidence of PJK issues go up significantly. And so really, the patients who are getting PJK are those whose apices are moving higher and higher with each successive operation. One thing I want to talk about is also the bone quality issue, which I think is incredibly important. And this was a paper from Mitsuru Yagi demonstrating that the revision rates for PJK were higher in those who did not have Forteo preoperatively. And overall, however, we have to consider the context of this, since the overall PJK rates between the two groups were not different. A little conflicting data there, but I think we know that bone quality is important, and we got to optimize that. We're not going to be able to tolerate certain corrections for patients with the instrumentation that we have now, which is much more advanced than 20, 30 years ago, such as isolated Harrington rods. We have instrumentation now that allows us to dial in that correction, and perhaps that's why we're also seeing a higher rate of junctional kyphosis. So I'm just going to go through quickly here a couple of case examples. Maybe not this one, but I'll go through something that I think is very telling for the proportionality issue. Here's a case of a 68-year-old who had back pain, some pain when she feels like she's leaning forward, and no real leg pain issues, but she had a history of a high-grade spondy in the past, and she had this prior operation that was done in 2010 from a T4 to pelvis. So if we do a close-up here, you can see that she has a high-grade spondy at 5'1", which was sort of fused in situ, and she had this lumbar curve, which was also not really corrected, and her coronal and sagittal balance is not optimal. She has PJK at the proximal segment. These are supine CT scouts demonstrating the rigidity of the construct. You can see a broken rod there for the sake of time at the L3-4 segment with some vacuum disc suggesting that there's a pseudoarthrosis at the segment. And indeed, you can see a cut here demonstrating the rod failure and a junctional kyphosis issue with some screw pull out posteriorly and no significant cord compression. The patient was not myelopathic, but something that definitely would need to be addressed in a revision setting. So I think many years ago, we would have looked at this, or I would have looked at this and said, hey, she has a pseudo at 3-4. She was really pretty functional before that. Why not just fix the pseudo, try to give her a little bit more lordosis and fix the PJK and call it a day? But I think today, the way that we understand alignment, we should really be trying to restore this patient to something that's more physiologic, restoring the lumbar lordosis from L4 to S1, trying to take care of the lumbosacral kyphosis that she has because of the in situ fusion that she had at 5'1". So what I ended up doing was a T2 to pelvis revision with a S1 PSO. I felt like I needed to attack the deformity at the apex, which was the L5S1, address the pseudo at L34, as well as extending her up higher. And this patient is now 5 years post-op, doing very well. And immediately after surgery, even as fast as 6 weeks, as she was recovering from the initial trauma of the operation, she said her body felt totally different, and she hadn't felt this way in years. So I think that's something that's really telling, and as we're understanding alignment more and more, I think we could improve our outcomes for our patients more and more as well. So that's it. Thank you. It's been time.